Thank you for joining us on our Driving Quality Navigating Healthcare with Leading Age Illinois and Iowa webcast. In this episode, we'll be discussing the short and long stay measure related to antipsychotic medication. I'm Kelly Van Reed, the Director of Clinical Services with Leading Age Illinois and Iowa, and I help members with their clinical and regulatory needs. I'm joined by my colleague, Jason Speaks. Jason, would you like to say a few words?
Sure. Hey, thanks, Kelly. And this is an important topic, and I'm glad to be a part of this discussion. Jason Speaks, as Kelly mentioned. I am the Director of Government Relations for Leading Age Illinois. And the use of antipsychotic medications in nursing homes has long been a topic of discussion among advocates and legislators here in Illinois. I can recall this being even a bigger topic over discussions with legislators over the last 10 years or so, starting in about 2015. I remember it being kind of a focal issue in the General Assembly, and some studies being done by AARP and other advocacy organizations focused on antipsychotic medication use in nursing homes. A lot of this is because Illinois' average is about 19.8% of long-stay residents receiving antipsychotic care, which is about 5% higher than the national average. That's why this has been a focal point of Illinois legislators as well as those at the federal level from time to time looking at Illinois. And this webcast, as I said, is very timely since CMS continues this national crackdown on inappropriate antipsychotic use. And they recently issued guidance, which Kelly's going to talk about, giving some updates for antipsychotics and surveyor focus. Also, I know that, and Kelly may mention this as well in our updates, but Leading Age National has recently joined the Project Pause Coalition advocacy group, and they are pressing Congress for action on safe antipsychotic use in nursing homes nationwide. So again, a very important topic, very timely, Kelly, that you've are doing this webcast on this issue, and I'm looking forward to hearing more of your presentation. So thanks for giving me an opportunity to introduce myself.
Yeah, thanks, Jason. That's great information. And obviously, we'll look forward to more changes in the future that we can continue to pass along to members. So today we're going to discuss the numerator and denominator specifications for both the short and long stay antipsychotic medication use with your quality measure. Additionally, we will look at the exclusions for the numerators and denominators, and then finish our discussion on some strategies for improving your antipsychotic measure ratings. So first, let's talk about how CMS calculates your antipsychotic measures. For the short stay antipsychotic measures, CMS is calculating the number of short stay residents who started an antipsychotic during their stay. So this numerator is calculated by determining the short stay residents, and short stay is defined as those that are in your nursing home for 100 days or less, that had an admission MDS and a subsequent MDS throughout their short stay. So a subsequent MDS would likely be your skilled discharge MDS that you complete. On the admission MDS, you would code N0415A1, which is asking about antipsychotic medication use through the reference period, would be coded as on the admission, it would not be coded, excuse me. And then throughout the stay, so that next MDS that you do, either an IPA or a discharge assessment, would then have the antipsychotic coded, which would indicate that that person started an antipsychotic during their short stay at the nursing home. Um, of course, this is all unless the resident is excluded based on criteria that we'll talk about here in a couple of minutes. So the denominator includes all Medicare short stay residents who have an initial and subsequent MDS assessments within the measure target period and are not excluded from the measure criteria. So on this slide, you'll see the exclusions for the short stay measure. For the numerator, the resident will be excluded if the admission or 5-day PPS MDS was coded for an antipsychotic measure So that would mean that it was checkmarked on admission, and that would indicate that the antipsychotic was not new for that resident. So then it wouldn't be included in the numerator of your short stay measure. This could inadvertently exclude some residents who possibly started an antipsychotic in the nursing home, but maybe wasn't started for the first few days. So maybe they were admitted without an antipsychotic medication, but on day 3, they were prescribed an antipsychotic, and the ARD included that day 3 of the skilled stay as coding in the RAI manual. Um, so it just must be used anytime within that 7-day ARD, but does not require that it's used for the full 7-day look back period to be counted. So that could be one thing that may skew those figures a little bit. The denominator exclusions include any residents that have coded diagnosis of 5250, which is Huntington's disease, I-5350, which is Tourette's syndrome, or I-6000, which is schizophrenia. So if the resident would have been included in the numerator, but then you have one of the 3 diagnosis codes that are included in your MDS, they would be excluded from the measure, both the numerator and the denominator.
So Kelly, hold on. I hate to interrupt. This is good information, some of which I did not know, which is why I have a question right now, if I may. So since the short stay measures new antipsychotic use during the resident stay, does the long stay quality measure also include only new antipsychotics?
That's a great question. And the answer is no. So the long stay measure includes all residents who are classified as a long stay resident and take antipsychotic medication. So let's look at that numerator and denominator. So for the long stay quality measure, the numerator is any MDS submitted in the target period that includes coding for N0415A1 equals 1 or is checked mark as the resident is using antipsychotics during the assessment reference period. The denominator includes all long stay residents, with the definition of a long stay resident being someone who is in the nursing home for 101 or more days without a 30-day lapse. So similar to the short stay measure, exclusions for the long stay measures include coding um, either the Huntington's disease, the Tourette's syndrome diagnosis, or for schizophrenia. Note the only difference with the long stay measure is that coding 1 for I-5350 on any MDS during the long stay measure period, even if it's not the same assessment that is coded with the antipsychotic medication, will exclude the resident from that measure.
So it's interesting that you bring a lot of these points up. And as I mentioned in my, introducing myself, CMS has been focusing on these medications for a while, even here recently, as you've, been mentioning. So like I said, it's interesting that you bring up schizophrenia, excluding a resident from this measure, as CMS has been focused on nursing homes misdiagnosing residents with schizophrenia. So that's an interesting point that you made.
Yeah, so let's talk about how we got to where we are today. Once some providers became aware of this exclusion, an increase in the number of residents diagnosed with schizophrenia was noted, and it alarmed the Office of Inspector General, or the OIG. So, based on findings from an investigation by the OIG, CMS began conducting audits of resident records that had these diagnoses of schizophrenia and were excluded from the measure, and found that a lot of these diagnoses did not meet the clinical criteria that's outlined in the Diagnostic and Statistical Manual to receive a diagnosis of schizophrenia. So fast forward to today, CMS has included in the most recent revisions of the interpretive guidance directions for surveyors to review resident records that have these diagnoses to ensure that it's supported by adequate documentation as outlined in the DSM. So F658 in Appendix PP outlines that the nursing homes must use evidence-based criteria and professional standards to code a diagnosis in the MDS. So while you may have practitioners who continue to erroneously diagnose schizophrenia, the person coding the MDS has an obligation to code the MDS accurately. So, similar to an infection, if there's not adequate supporting documentation of that diagnosis, the nursing home staff should not code schizophrenia, even if it is diagnosed by a physician. So, examples of insufficient supporting documentation include that schizophrenia is an indication of medication use, but it does not have supporting documentation of a diagnosis. So, for example, when you're looking at your physician's order, it says to administer Seroquel for schizophrenia, even though you would indicate on your MDS that it has an indication for use. You may not have that supporting documentation to code it as a diagnosis in Section I. The nursing home may also request the practitioner to diagnose schizophrenia without that supporting documentation, which would also um, include insufficient supporting documentation. Perhaps you have a note on a transfer or a discharge summary that includes a diagnosis, but there's no evidence that a comprehensive evaluation was completed to adequately diagnose. So if you have a resident that comes to you from the hospital or another location and they have a diagnosis of schizophrenia, you want to make sure that you're documenting in the records that you're making sufficient attempts to try and gain that information as to when they receive that diagnosis. Typically, one thing that they say, for example, is that someone at the age of 70 is not likely to be newly diagnosed as schizophrenia. It's usually something that is diagnosed in younger adulthood, people in their 20s versus somebody who is in their 70s. And through interoperability, the diagnosis is added to your electronic health record, but you still don't have that supporting evidence. So perhaps somebody in the clinic setting has entered um, the diagnosis code for schizophrenia, which then communicates to your electronic health record that they have the diagnosis, but you still don't have that supporting documentation to be compliant. So additionally, the regulations indicate that all of the following must be present in the record to be compliant. So you have to have documentation of symptoms, disturbances, or behaviors consistent with the DSM for the period of time that the DSM requires. So there may be, a period of several months where you need to have documentation of this that you would then include in your charting. Documentation from the diagnosing practitioner that the diagnosis was based on a comprehensive assessment, that they have the symptoms, disturbances, and behaviors, and that they're not attributable to effects of a substance or any other medical condition. So, for example, if somebody is hallucinating, they want to make sure that diagnosing practitioner is doing their due diligence and trying to identify if there's some kind of underlying infection or if there may be something such as dementia that would be causing that hallucination compared to schizophrenia. Also, that documentation of the disturbances impacts the resident's function, including interpersonal relationships, potential self-care, etc., which is why you tend to find this more in younger adulthood than individuals who are, into their older adult years. So, Jason, do you want to share with members why this measure is important to us, like right now?
Sure, yeah. What I like to do is kind of talk about some of the staffing incentives that have come to Illinois and have been a part of Illinois, particularly over the last probably since 2022, so 3+ years. That includes the quality incentive payments. Our association, our members have always been about staffing and quality. And in discussions with Medicaid rate reform in 2021, 22, and beyond, we've always pushed staffing and quality and wanted to see those outcomes and see Medicaid reimbursement reflect that. So we've got the quality incentive payment program based on your star rating. Illinois operates this program for Medicaid funded nursing homes. It is structured with $70 million per year. That's about 17.5 million per quarter that's been established here in Illinois. Another aspect of our these payments and incentives is the staffing level incentive payments based on your strive. Illinois implemented this value-based payment strategy to improve staffing quality, something we were very happy about, where staffing incentives are tied to performance relative to CMS's Strive staffing targets, which, as you know, that's the government's case mix adjusted estimates of required staffing levels. There also is, and this was in 2021, 2022 also, the CNA pay scale subsidy and promotion payments that some of our members receive and providers in Illinois receive. And that's to support CNAs in Illinois. And it provides a CNA pay scale subsidy, incentivizing higher wages based on your CNA experience with Medicaid coverage, part of that increase. Additionally, there's promotion-based payments that offer Medicaid share. So an example is $1.50 per hour for CNAs in elevated roles such as, trainers, dementia specialists, etc. And these programs encourage, retention of experienced and permanent CNAs, and also they reduce the reliance on temporary staff and staffing agencies, which during the pandemic and even beyond has been a major financial strain on providers. There also is here recently, as of this last General Assembly session that concluded in late May, an updated staffing add-on in your rates. So that expands the staffing incentive structure. So those are probably about a handful of examples that I can give.
Yeah, and I could foresee in the future looking at things like antipsychotic use as a measure of quality,
Yeah.
and incorporating that into payments. And I know Jason's an expert in Illinois. We don't really have much of a quality incentive program in Iowa, but it could be something as we're looking at some of these bills that are coming down from the One Big Beautiful Bill Act, that potentially helps drive Medicaid rates for Iowa members as well.
Yeah, we're still looking, along with our national association, looking at the impact of the Big Beautiful Bill. We were discussing with state legislators to see what their response is going to be here in the coming General Assembly session. Also with federal legislators. In fact, this week, at the end of this week, myself will be meeting with a Congressperson, Nikki Budzinski, who's scheduled a meeting to talk about the impact on Illinois. So those discussions are lively and happening right now, and we're hoping to have a lot more information for providers and our members, within the next few weeks or so.
So let's talk about how you can improve these measures if you're one of those that has a higher rate of your antipsychotics. So the first thing that you should do is to identify which residents are included in your numerator and denominator. So you can find this out by pulling your resident level reports from iKey's system. And then based on the residents that are included in your rates, I strongly recommend that you prioritize individuals to try to reduce the antipsychotic numbers. So for example, if you have a resident with a significant mental illness, don't start on this person first until you've worked through some of the other residents that maybe just have a dementia with a behavior diagnosis that could be more beneficial at reducing those antipsychotics. Also make sure that you are working with mental health practitioners that may be involved in the resident's care, and making those decisions based on called a multidisciplinary approach. The website that I've included on this slide is from the QIN, or the Quality Improvement Network, and they have a link that provides strategies on prioritizing residents that you may find helpful. So once you identify those residents that you feel are appropriate to try to discontinue antipsychotics, make sure that you go slow and steady as you try to reduce them. reduce the dose, and then wait a period of time before you try to reduce again. So this may not be something that you can accomplish in a week's time, but it may take months to try to see some improvement within this quality measure. The other website that is included on the slides discusses this topic and provides information on best practices. So don't forget that if you successfully discontinue the antipsychotic, you will want to make sure that you complete an MDS, even though it may be an off-cycle MDS. But this is the way that those residents are removed from your numerator on the quality measure report. Um, in addition to reducing the number of residents on an antipsychotic, you will want to incorporate strategies into your behavior management strategies programs. So there are several things that you can consider using in your nursing home to work on this aspect. So first, implement strategies to identify the root cause of the behaviors that residents are displaying. If you can identify the root cause, then you're able to hopefully reduce the behavior without that use of antipsychotic. Additionally, if you do need pharmacological assistance to reduce those behaviors, you may consider alternative medications to antipsychotics. So for example, if you can look at the root cause, you may identify that the underlying cause is anxiety, which may be treated by an anxiety medication instead of an antipsychotic, which may have a few less side effects to it. With an interdisciplinary approach, you can establish a behavior review team or a system to identify residents that may be at risk of staff requesting pharmacological assistance to manage those behaviors. The resources on the website have practices for this process that may assist you in implementing this approach. Additionally, ensure that your staff are educated and have a good list of non-pharmacological interventions to try when a resident is having behaviors. I recently used the assistance of ChatGPT to establish a list of 50 non-pharmacological interventions based on the type of behavior that is being exhibited by the resident. You can find this resource on and many more on our websites if you would like to make it available for your staff to have handy for them. You also want to ensure that your staff have robust education on managing behaviors and what your practices are. So for example, as a DON, I had a practice that staff were to attempt at least 3 non-pharmacological interventions before they could administer an as-needed psychotropic medication. And then they had a form for them to indicate what the behavior is, along with the non-pharmacological interventions that were attempted, which would be placed in the medical record and used as part of the documentation strategy to ensure that we had documentation supporting the use of that pharmacological agent. Finally, once you have staff that are well-trained and do a good job managing behaviors, you can consider using consistent staff assignments to help reduce behaviors and the use of psychotropic medication. So this also helps the staff know the residents to identify possible triggers to behaviors or early signs that the resident may be experiencing distress, such as a resident who begins wandering when they need to use the restroom. Some residents just respond better to particular staff as well when they are experiencing behaviors. I recall personally caring for a specific resident that would frequently get agitated thinking that the staff were locking them up in various places. I was able to visit the resident and take them to a different location in the building, which seemed to reset their mind and felt like she was being removed from the location that she was being locked up in. Once her behavior subsided, we were able to return to the area and the resident was better. Jason, is there anything else that you feel is pertinent for our members to know on this topic?
I think you covered it all. This is always going to be an important issue and always a matter of quality of care, resident safety, dignity. And, I think that, as I mentioned early on in the webcast, leading age being a part of a national coalition is just one more step in that direction, also. So I think our members can take these insights that you shared today back to their organizations and continue to educate staff on this topic. And you provided some great resources And thanks for letting me be a part of it today.
Yeah, thanks for joining me, and thanks for taking the time to listen to our webcast today. Join us for our next topic of pressure ulcers. And don't forget to complete our survey to let us know what you think of these webcasts or what kind of topics you'd like to see us cover in the future. We hope you have a great day.